Hi again. I have some different disclosures for this talk. So it's actually very interesting that I'm the individual who's tasked with talking about this therapy with so many people on the panel and in the audience that have been doing this for a lot longer than I have. But when we talk about these types of patients, these no-option patients, we all can conjure a mental image in our head, right? These patients don't have distal targets for open bypass, or they're patients who have really high SAD scores and MAC scores, who have severe calcification, heavy plaques, the types of lesions that we see and know that are either going to recoil if we can open them up with balloons or atherectomy, or they'll subsequently fail with endovascular therapy. When I think of a desert foot, though, I think of somebody who has absolutely nothing lighting up below the ankle. They don't have plantar arteries. I can't see a dorsalis pedis or a lateral tarsal artery. And when we talk about this group of patients, it constitutes 20% of patients with critical limb-threatening ischemia, right? So generally speaking, these patients who have desert feet are angiographically adjudicated, right? We can use arterial non-invasives, and not everybody has access to PATs like Miguel does, but I make these decisions based upon the angiograms that are performed. And these angiograms can correspond with a variety of different physical presentations, right? Somebody who has a desert foot could have extensive forefoot gangrene, or they could have simply isolated hallux gangrene. So who are these interventions for, right? First and foremost, it's for committed patients, right? Surgery, delivering these therapies, is by far the easiest part of the management of them. Right? The patients need to be committed to coming back to the office for frequent wound checks and the potential for repeat endovascular intervention. And in order to do that, you need to make sure that these patients have good family support. They have people who bring them back to the office, whether it's the wound care office or the hospital, right? These wounds need to be stable, and the location is critical. And there are anatomic considerations that we'll talk a little bit about as to who will do the best with these types of interventions. Because while Dr. Bernardo alluded to the fact that some people can have PTABs and DVAs, I don't know how bold I would be in providing that therapy at this time, right? And then other clinical considerations that we might have are their ambulatory status, their activity level, and other chronic comorbidities that they may have. As we know that end-stage renal disease, and in my opinion, heart failure with a depressed ejection fraction will lead to poor outcomes for these patients. Right, so you can see here, this is isolated hallux gangrene. This is a pretty stable appearing wound. It's not wet, it's minimal, and it doesn't look like there's that much infection, right? Or if there is infection in there, it looks like that type of infection would be able to be dealt with a simple foot debridement, right? This is slightly more extensive, right? This patient, when I look at this foot, I'm thinking, best case scenario, this patient's gonna heal a TMA. This is someone that'll probably do okay with a PDVA or a TADV. Right? But then when you deal with a foot like this, right, where the entire forefoot and almost up to the level of the calcaneus is gangrenous, these aren't patients who are going to do well with any therapy apart from major amputation. So we can start with this case, a 65-year-old patient that presented with right foot dry gangrene, previously underwent a popliteal aneurysm stent, and after the stent, she had long-standing rest pain. So when I heard this story, I was thinking, this patient obviously embolized from their popliteal aneurysm. She underwent repeat angiography at the outside facility that did her popliteal stent, and they basically said, we've got no options for you, you're gonna need a BKA. So they sent the patient over to me, and this is what her foot looked like. Arterial non-invasives, consistent with someone that I'd imagine might have a desert foot, normal ABIs bilaterally, but a toe pressure of the right lower extremity of 0. And a toe pressure on the left is 0, but she was asymptomatic. All these patients get reflexively upper and lower extremity vein mapping, and her conduits were quite small. So not a real good candidate for any sort of open bypass procedure. You can see here her angiogram. You can see a widely patent SFA with a popliteal or a proximal popliteal distal SFA stent and decent BK pop runoff. And then going distally, this patient has an occluded anterior tibial artery, single vessel runoff via a perineal artery, and the wisp of a common plantar artery at the ankle. So, because I'm a vascular surgeon, rely on the Wi-Fi classification system. She's Wi-Fi 230, stage 4. This patient's either gonna need a revascularization or an amputation, right? Patient's absolutely adamant that they refused an amputation. This patient's got a desert foot. She's a no-option patient, but she has no autogenous conduit. And the person that sent her to me is a pretty good endovascular operator. So when they told me that they couldn't cross from below, sent them for a DVA, so the patient's going to get a DVA. Right? There are some hypotheses, which at this point in time I think are all theoretical, whether or not the mechanical component of creating a deep venous arterialization and sending blood actually into the metatarsal and plantar venous system will provide perfusion to facilitate healing, or whether or not this actual creation leads to the recruitment of hibernating arterial collaterals and fundamentally leads to angiogenesis. I think there's a lot more research that needs to be done. But the procedural steps of this procedure, first and foremost, get arterial access, get your venous access, create your fistula between your tibial artery and the corresponding tibial vein, wire from plantar to dorsal venous circulation, stent your venous tibial tract, and then disrupt the valves below the ankle, right? So a lot of different people do these a variety of different ways, but I think you have to do them antegrade. So my scrub table is positioned at 90 degrees from my access. Depending if I'm using an off-the-shelf technology, I'll use a 5/6 slender sheath in the superficial femoral artery or the common femoral artery. And if you're using the LimFlow TAD-V system, you're using a 7 French system. And then ultragrade, retrograde venous access, ultrasound-guided retrograde venous access. I most commonly, historically, have done them from the posterior tibial vein at the ankle, but a lot of people do them utilizing lateral plantar vein access. We start with our angiogram, and then a phleboangiogram to delineate where the closest overlap area, your target area, is going to be. Unfortunately for this patient, this was the TP trunk, right? And the ideal donor artery, or the artery that you're using to connect to your vein, is not the main source of flow to the foot, right? And you want at least 2 centimeters of landing zone for stent placement. So this patient's TP trunk, perineal artery, was not the ideal donor artery. That being said, we ultimately crossed using off-the-shelf technology. I rely on the Pioneer ultrasound-guided reentry device. You can see here crossing from the artery into the vein. Other well-documented techniques that people utilize to reenter is the gun-sight method or the VAS method, popularized by Dr. Siah in Spain. And this uses 2 5 French snares. You snare the wire, you snare the needle from an external puncture through both arteries and veins, advance an 014 wire, and then utilizing both snares, you pull out one from below and one from above, and you can have through and through access. Now we have access to the LimFlow systems, FDA approved, and this system using the V-Seaver and the ARC has fundamentally revolutionized crossing. It's just cut down so much time on actually crossing and creating these fistulas. Following through and through access, I get a 4x200 balloon, irrespective of the size of the patient's native vessels, and you can see there that little stenosis or waste is the actual fistula connection. After I've created the fistula, I get an 035 support catheter, bring that down to the level of my access, and then buddy wire an 018 wire through that and get around from plantar to dorsal venous circulation. And here is one of the real big challenges that remained. I think this is one of the similarities between the PTAB technology and doing PDVA or TAD-V is dealing with these valves or these reentry areas. So something that I've relied upon are specialty balloons, most notably the Serenator. So I use a 5x120 Serenator, typically to lyse or affect the valves in the tibial veins. And there's usually some really, really aggressive valves at the level of the ankle or below the ankle. And I still use it even when I'm doing my LimFlow cases, despite the fact that we have access to a forward-cutting valvulotome. Then below the ankle, one of the things that I like to use is a cutting balloon, and for whatever reason that's not playing, but I pull it back like a Fogarty over the wire to lyse all the valves in the forefoot. There are a variety of different stents you have available to you. The LimFlow system allows you to use a conical stent graft and cylindrical stent graft as opposed to simply using long segment Viabonds, and we typically stent to the level of the mid-calcaneus. And completion angiography after that, we can see brisk filling all the way down through the calf into the forefoot.
Nice.
And wound management following PDVA and TAD-V is fundamentally different. You need to wait 4 to 6 weeks to allow for the procedure to mature. So there's only early debridement and absolutely no closure. And that's what an open TMA looks like at 4 weeks. We see flow velocities through the stent of nearly 200 cc's a minute. With VAC therapy, these things can sometimes look pretty ugly, right? Anytime you put a VAC on something, there's a chance that the skin can become macerated, so we can switch to wet to dries, intermittently going back and forth. And then prior to any coverage or closure, I'll take these patients back for a completion venogram or a lower extremity angiogram just to see what's going on before any skin grafting or anything like that. And you can see that this arteriogram at 2 months after our index procedure looks fundamentally different. We see arterialized flow going out to the edge of that TMA, and those small blood vessels are facilitating wound blush. So I feel like this patient is really well perfused. These patients get covered with skin substitutes, and then secondarily, eventually they heal at 3 months. Right, so in my experience, we had 79% amputation-free survival, 44% complete wound healing at 6 months. 21% of these patients, though, all patients who underwent amputation died. And that's similar to the experience purported by the lymph flow investigators. So TADV, PDVA seems to be an effective treatment in no-option CLTI patients, and this is a therapy reserved for patients who'd otherwise undergo major amputation. There's more questions remain, and I'm sure a lot of people on this panel and in the audience today have a lot of insight into where future directions for research need to go. Thank you.